everyone, I am Dr. Eben Jose, and in this video I'll be speaking about mesenteric ischemia and the role of interventional radiology. This is the classification of mesenteric ischemia. It is divided into acute and chronic, and in acute you have arterial occlusion, venous occlusion, and non-occlusive disease, and in arterial occlusion you have embolic and thrombotic. In AMI, that is acute mesenteric ischemia, it is a life-threatening vascular emergency with a very high mortality rate of 60 to 80, and the only way to reduce this mortality is early revascularization through intervention. So here in the clinical presentation, you often find some underlying heart disease and atrial fibrillation, atherosclerotic disease, a typical postprandial pain, acute severe mid-abdominal pain, and in the labs you can find leukocytosis, lactic acidosis, and sometimes elevated liver enzyme. And when you do a CT, you in the early AMIs you can find bowel dilatation, bowel wall edema, ascites. However, these changes are reversible to an extent, and in the late disease you can have a pneumatosis, intestinal pneumoperitoneum, intravascular gas. So in arterial embolism, so that is the 50% of the cases. Here SMA is very susceptible because of the high flow and the acute takeoff, and majority of the embolus will be located around 6 to 8 centimeters from the SMA origin, as you can see in the CT scan, and here in the DSA also you can see embolism over here, and the etiology is often from cardiac sources, and there is very less likely that there is collateral circulation in acute embolism. In arterial thrombus, it will include around 25% of the cases. Here there will be underlying pre-existing stenosis. So here you can see it will be at the origin of the SMA, the thrombosis. So they can be associated postprandial pain, and they could have collateral vessels. And however, the prognosis is worse than embolism. And another type of case could be aortic dissection. This is pretty rare compared to the rest. So here there will be a dissection flap that is extending into SMA, and this SMA will be perfused by the false lumen of the dissection. NOMI is non-occlusive AMI. So this is 25% of the cases. So this is associated with a prolonged hypotensive event, and there could be vasopressors used, though that could also be a cause. Another cause could be drugs like cocaine and digitalis. So here in the CT you can see there is diffuse arterial vasoconstriction, and definitely there could be reduced opacification of the bowel. However, the mesenteric venous plexus will be normal. Mesenteric venous thrombosis, so this will include around 5 to 10% of the cases, and they are associated with hypercoagulability, trauma, prior surgery, inflammatory disorders. So here you can see the SMV is completely thrombosed. Chronic mesenteric ischemia, also known as intestinal angina. So by definition there should be occlusion or severe stenosis of 2 out of 3 major mesenteric vessels, that is celiac, SMA, IMA. But nowadays they say even 1 out of 3 is enough to come into CMI. So clinical presentation, there will be recurrent postprandial pain. So that will be around immediately, shortly after eating food, and it will last around 1 to 2 hours. So why this pain after postprandial after food is because of the after food, once the digestive system is activated, there is an increased need for more blood flow, which is not met because of the stenosis, and that can lead to transient reversible ischemia, and that is the cause of the postprandial pain. So here once we plan to intervene, let's see the different criteria. So in AMI it is predominantly endovascular if there is a low suspicion for intestinal necrosis, and in CMI also it's usually endovascular first, and if it fails you can go for surgical options. In NOMI you have to treat the underlying cause of the hypotension, and then further you can go on for catheter directed infusion of papaverine into SMA. In mesenteric venous thrombosis, if the patient is asymptomatic, we'll just initiate systemic anticoagulation and just supportive care. However, if the patient is worsening, then we'll go for endovascular therapies. What are the contraindications to intervention? So predominantly when the disease has progressed too much, and when the bowel infarction has already set in, peritoneal signs are there, or lactic acidosis, or other contraindications to intervention in general, that is contraindication to contrast allergy or any renal insufficiency or active bleeding, recent surgery, etc. So once we have planned the procedure, the axis could be femoral axis or a brachial axis. So in SMA, brachial axis could be taken whenever the SMA angle is bad, or when there is a bad aortoiliac occlusion, or when you want to deploy a precise stent. So a brachial could be preferred. So you do a flush angiogram with a pigtail preferably, and you obtain abdominal aortic DSA, AP and lateral. Here you usually give a bolus dose of heparin of 5000 units followed by a slow infusion. And the vasodilators we predominantly use are papaverine. And for the thrombolytic therapy we can use TPA or the recombinant TPAs like alteplase, retiplase and tenecteplase. In acute embolic or thrombotic occlusion, the primary goal is rapid revascularization. So when you do catheter directed thrombolysis, so you initially put a fountain catheter into the thrombosed artery, let it be, let's say it's SMA, and then you give a bolus dose and a long infusion and wait for it to recanalize. Another method could be catheter suction embolectomy, where you will advance a large caliber sheath into the SMA and you will just put proximal to the embolus and aspirate using a large capacity syringe, 20 cc or a 50 cc. So once you have planned a mesenteric artery stenting, so many a times the brachial artery approach is used for a stent deployment. So here mainly you need a strong catheter system. So here mainly we can use a 7 French long 90 centimeter sheath, and then for inside that you can use a 7 French guide catheter, and inside that you can use a 5 French MPA. And you can use initially the target lesion will be crossed using a 3-5 wire. It can be an angled glide wire or a soft straight, and once you have crossed it you can use the intervention wire of your choice. It could be an 18 wire or a 14 wire, and you can deploy a stent, and a stent could be a covered or an uncovered stent, and we should definitely try to avoid any side branches. And nowadays filters can also be used, that is distal embolic protection can be used. And distal embolic protection is usually over an O14 wire, but however when the stent is 3-5, you can use a 2 wire technique where you will use a O14 wire, that is for the distal embolic protection, and an 18 wire also as a buddy wire into the same SMA, and the stent is introduced over both these wires, so better support. So this is for the embolic protection device. So indications for it will be severe calcification, acute thrombus and total occlusion. So here you can see this is a long sheath, inside that a guide catheter and a small 5 French diagnostic catheter, that could be a MPA. And initially you will cross the lesion with a 3-5 wire, and then you will exchange it for a 14 wire, use a distal embolic protection, put an 18 wire also, and through that you can put a 35 compatible stent, and you can deploy the stent. So post stent deployment, once you retrieve this filter device, and you can see there are a lot of emboli that is caught by this distal embolic protection. So there's another case where there is a stenosis in the SMA, and where you have deployed 2 distal protection devices, and you are putting a stent over here, and this is the post retrieval of that embolic protection device. You can see there are many emboli that is caught in this. This is a case of celiac artery and SMA stenosis. So SMA, you have a short segment lesion over here, following which 2 stents were deployed. However, during the deployment there was a distal embolus which was aspirated using an aspiration catheter, and this was the final DSA, which is looking good. And this is the distal embolic protection, and these are the debris that was found within it. In case of NOMI, you have to selectively catheterize the SMA, and you should initiate papaverine infusion. Initially give a bolus and then followed by a continuous infusion, and typically it will require at least a 24-hour infusion. However, you should assess again within 12 to 24 hours. So this is a case of NOMI. This is prior to the infusion and this is post infusion, which shows significant dilatation. Here also there is severe vasoconstriction here prior to it, and this post infusion it is showing some good caliber. In case of dissection, there can be compression of the true lumen by an enlarging false lumen. There could be extension of the aortic dissection flap into the SMA, or hypoperfusion of SMA when it's arising from the false lumens. And here the lateral angiogram showed an irregularity in proximal SMA, and on the AP it was confirmed that it was a dissection. Distal access was taken, and there was a rapid restoration of proximal SMA that was done by tracking down the dissection flap with the help of two non-covered self-expanding stents, and the post-procedure DSA is looking good. Chronic mesenteric ischemia, here you can confirm the stenosis by measuring the pressure. More than 20 is significant, 10 to 20 is borderline, and less than 10 is not significant. So the present trend is towards stenting rather than angioplasty. However, if it is a severe stenosis, you'll have to do a pre-stenting angioplasty, likely with a 4 mm stent. So predominantly we use bare metal stents. However, new studies have shown that cover stents are better for a long-term patency. So here when you deploy the stent, a small part of the stent should be extending into the aortic lumen, and a single vessel revascularization is usually enough to relieve the symptoms. So over here you can see there is a severe stenosis of SMA and the celiac artery is occluded. So here the wire was passed into the SMA and a balloon mounted stent was deployed. So here you can see a small part of the stent is deployed into the aorta, which is how we want it. So in this patient, antiplatelet therapy was immediately started and the symptoms resolved completely. So here also there is stenosis of the celiac artery and severe stenosis of the SMA. So the SMA stenting was done and the post-procedure angio is also looking good. Here a prior SMA stent was deployed, but this patient had an acute and chronic abdominal pain and USG showed an occluded stent. So here in the DSA you can see the stent is occluded and brachial access was taken and the wire was passed distally, and angioplasty was done using a 6 mm balloon. And following angioplasty you can see the stent is patent again. However, there is small intimal hyperplasia over here which was kept on monitoring, and there's a post-procedure DSA which showed a revascularization. So here also there is a severe stenosis of SMA. The celiac is pretty good. So distal access was taken and a stent was deployed. However, during the stent deployed, there was a small distal emboli. However, the patient was asymptomatic and therefore systemically patient was heparinized. So this is a malpositioned stent. You can see the first stent was jetting too much into the aorta and did not cover the SMA lesion. So another overlapping stent was deployed. In case of SMA thrombosis, conservative management is always the first line. You go for systemic anticoagulation and supportive care. We only go for endovascular treatment only if the symptoms worsen, and that time we can go for thrombolysis, thrombectomy, angioplasty, or a stent placement. And the route we predominantly prefer, it could be right IJV, transhepatic venous access, tips like approach to SMB, or you can go for percutaneous transhepatic venous access. This is a case of SMV thrombosis where thrombolysis was done, and this is the follow-up DSA that showed a complete patency of the SMV. Here also there is an SMV thrombus, catheter directed thrombolysis was done and recanalization was seen. So post procedure it is better to monitor the patient in ICU, NPO for at least 12 hours, monitor for lactic acidosis and consider for total parenteral nutrition. And there could be reperfusion injury. If it is suspected, give IV glucagon. Anticoagulation, titrate IV heparin to partial thromboplastin time of 60 to 80. Antibiotics, piptas, metronidazole, levoflox. Antiplatelets, whenever you put a stent, you have to initiate antiplatelet therapy. Aspirin 150 per day and clopi 300 loading and then 75 mg per day, and continue at least the dual antiplatelets for 3 to 6 months and aspirin indefinitely. And post hospitalization clinical follow-up should be 30-day OPD visit and then CT angio 6 and 12 months. Surgical options could be surgical exploratory laparotomy, for the gangrenous bowel or mesenteric bypass. And in case of medial acute ligament, surgical decompression can be done and a follow-up DSA can be done just to see the resolution. So here you can see in the CT angio and the DSA, the celiac artery origin is severely narrowed, and here you can see the right and the left diaphragmatic crura join to form a median acute ligament, and it's a fibrous arch that compresses the celiac artery.